Hello class, in this presentation we're going to discuss some aspects of arthritis and neoplasm. So we'll start with degenerative arthritis. By far it's most common arthritis affecting the hip. When you consider degenerative arthritis, obviously disease of cartilage, that's the key pathology. Most of the changes that we're going to see radiographically represent some sort of pathological process affecting initially cartilage and then adjacent subarticular bone. So typically it presents with some kind of fragmentation, some sort of stripping and breaking of the articular cartilage and basically exposing the subarticular bone. This nice pathological specimen can actually demonstrate this normal cartilage. You can see it's very nice and thick. It's actually nice and very smooth, evenly arranged chondrocytes. You can see it's sort of uninterrupted. It's very smooth and continuous versus perhaps some of this fragmentation, fissuring, pitting, all these changes sort of this with the cartilage with chondrocyte being kind of elongated and pushed towards the periphery, and that kind of indicates that histological process affecting the cartilage, some kind of cartilage destruction. So remember, osteoarthritis, disease of the cartilage, that's where it usually begins. Later on, subarticular bone will be exposed, but cartilage becoming thin and denuded, basically stripped off and lost, and that's a process known as hibernation. You can see some of these reactive vascular changes, sort of hypervascularity will put down like a basic deposition of bone leading to subchondral sclerosis that later on we're going to see radiographically, but that doesn't make that bone stronger. In fact, it becomes much more brittle, prone to fragmentation, microfracturing, and then cystic changes. In this case, you can see process of hibernation, sort of the thinning of that normal kind of, if you like, cartilage and articular bone. You can also see some of those ischemic, basically trophic changes. The bone becomes very kind of brittle, fragmented, and basically start being destroyed. That's kind of because you lose that cartilage. At the same time, you can see this large subchondral cyst formation with destruction of that bone. The important thing to understand with osteoarthritis, particularly about the hip, that although it's considered to be primary osteoarthritis, however, we see this different sort of variation in ages. So typically you may have a patient who in their 80s completely normal hip versus patient in their 40s or 50s with some sort of hip osteoarthritis away of the hip. And for that reason, people started kind of suspecting that might be some kind of causes involved, and usually, there can be multiple causes, but more recently, somewhere in the 90s, the important cause of osteoarthritis was identified as femoral stabular impingement syndrome. We'll talk about it very, very quickly. But other causes also should be considered. Again, avascular necrosis potentially can affect that bone, calcium pyrphosphate deposition, previously inflammatory arthritis such as RA because it destroys the cartilage and it may lead to some sort of superimposed osteoarthritis. Some childhood causes such as slip capital femoral epiphysis, Perthes disease, and any other kind of sometimes morphological changes in the morphology of the hip may also kind of predispose to osteoarthritis. Now remember, hip OA is second most common to knee OA, and women tend to be affected a little bit more than men, but again, both sexes will be affected. Especially if you consider some of those predisposing causes. It's considered to be a relatively common cause of symptomatic arthritis leading to potential morbidity and disability. Now, when you approach imaging evaluation, you can always start with X-ray. X-ray is pretty good to diagnose osteoarthritis. So what should you look at? Well, always look at the joint spacing. So the hip has compartments. So those three compartments in the joint, typically that's superior lateral axial compartment, and then medial compartment, which is thickest because there's lots of fat in the joint, but also some of that sort of cartilage, that horseshoe shape, additional sort of cartilage to, if you like, deepen and kind of support the joint as well. So typically with osteoarthritis, the pattern of joint space loss is usually non-uniform. In other words, the most common pattern, you're going to see some kind of potential narrowing of the superior lateral compartment. And that's the key that will help you differentiate between degenerative versus inflammatory arthritis. With inflammatory, cartilage destroyed simultaneously and the hip will migrate axially. In other words, symmetrical uniform joint space loss that you should consider. Now, the other features that you should consider, that's a nice mnemonic, kind of symbolizes that as loss. So loss of joint space, typically non-uniform. Also, some of the formation of osteophytes potentially develop. Here, we don't see many osteophytes, but that doesn't exclude osteoarthritis. In fact, you can see it's very severe osteoarthritis. So typically you can see that that joint space at the superior lateral compartment, you should at least have about 3 millimeters of that joint space. If it is severely narrowed, subchondral sclerosis, maybe that I mentioned to you, is much more denser deposition of articular bone, subarticular bone, with some sort of fragmentation leading to some of this large subchondral cyst and potential collapse. Other features you can see with osteoarthritis, typically in the hip, is that thickening of that medial aspect. Anatomically, it's called calcar femora. So that's kind of medial aspect of the femur is being thickened, and that's known as buttressing phenomenon. So it's a sort of like intra-articular type bone changes. Again, typically you can see that sort of non-uniform joint space loss, subchondral sclerosis, osteophyte formation. Typically when they happen, we call them collar type osteophytes. So they're somewhere along that femoral head-neck junction with a capsular attachment. In this case, you can see there's some bilateral changes in osteoarthritis. Not significant osteophyte formation, but certainly joint space narrowing, particularly non-uniform superior lateral compartment can be noted. A little bit more severe on the left with that reactive subchondral sclerosis. Again, cysts may form later, and some of those cystic changes are very important. We call them geoids. They're actually subchondral or subarticular cysts. Now, they're not exclusive to osteoarthritis. Rheumatoid arthritis can do that as well. Any kind of arthritis potentially destroying that cartilage can actually expose that subchondral bone, and that will potentially result with formation of those subarticular subchondral cysts. In this case, this is, by the way, CT scanning coronal reconstruction. You can see a nice formation of this osteophytes, collar type osteophytes along that femoral head neck junction, and both sides are affected, but they seems to be like non-uniform joint space loss. Medial compartment still relatively preserved, not significant, but certainly less joint space narrowing in the medial compartment. So that would be kind of more of a asymmetrical than non-uniform joint space loss. In severe cases like this, obviously referral to orthopedic surgeon is crucial. So that's how you determine whether it's mild, moderate, or severe. Look at the joint space loss. If it's just mild, maybe just a little bit less than 3 millimeters or so. But then progressive joint space loss, subchondral sclerosis, osteophyte formation, and some of this large subchondral cysts will help you to determine whether you're dealing with mild, moderate, or severe cases. And in many cases of severe or even moderate to severe changes, you should refer them to the orthopedic surgeon, because some of this total hip replacement can be actually life-saving for some of this patient, because it can help them to maintain the activity of daily living, perhaps minimizing comorbidities, and usually can be kind of literally life-saving for some of these patients. In this case, you can see a relatively severe progression of osteoarthritis untreated, and significant joint space loss, large subchondral sclerosis, massive osteophyte formation. Obviously, the person will be unable to do many activities, especially weight-bearing related activities. And that's a potential treatment for that. So typically when you do joint replacement, just very quickly so you're familiar with that when you examine the imaging. So in this case you can see cemented type arthroplasty versus non-cemented. So non-cemented, they're different fitting as well. So that could be metal on metal. It's literally just the sort of acetabular component. It's inserted into the acetabula. So metal on metal. Now remember, this metal is all titanium, so it's MRI compatible. So you can certainly order MRI for any of the patients with joint replacement anywhere in the body. Now it can be metal on metal, metal on basically on plastic, so basically that polyurethane, and then occasionally metal on, rather ceramic on ceramic. So the key in this case, you can see that femoral stem, in this case it's inserted with administration of cement. It's usually bone cement, some kind of calcium phosphate cement, and that tends to sort of fix that appliance right there. Now in other cases of non-cemented, that primarily used in younger patients than cemented, and usually there's sort of like a porous type material that when you insert that into the femoral stem, insert into the femur, bone tends to actually grow in and incorporate. It takes a little bit longer for it to kind of fix and heal fully, but it's much more stable potentially than the cemented. Therefore they use it in kind of younger people, and so on and so on. So you can see that sort of cement. So when we look at it, we typically want to examine that there's no widening of loosening of that cement. So if it's widening kind of greater than maybe 1.5, 2 millimeters, that's usually very significant for potential failure of this of this appliance, and we can look at some of those failures. So you can obviously have cement loosening, but you can also have a fracture of that metallic, basically, of your femoral stem that needs to kind of undergo some revision. You can have infection developing, which is, relatively, they consider it to be relatively infrequent, but I think it's sort of underreported. That's what studies show, potentially, because most of these patients present to some kind of secondary facility and where infection wasn't reported by the actual surgeon who performed the surgery. In some of the cases, you can actually have that stress riser and then potential fracture of the actual bone, periprosthetics, or the periprosthesis fracture of that bone. So all of this will potentially require some kind of revision. Particle disease may also develop. Particle disease is a strange entity, but again, it can develop due to sort of nanoparticles, some small particle released from the metal as well as from cement, and it kind of induces some sort of macrophage-driven immune type reaction in the joint, which can completely destroy that joint. Now, other causes that we should consider that predisposing to osteoarthritis very significant, and that's what I meant when certain causes were identified quite late, usually in the 90s. That's when cases started being reported of this, and it's known as femoral stability impingement syndrome, or FAI. You should definitely be aware of it and look for potential patients with it. Now, when a patient comes into you with hip pain, even if they're young, I don't personally believe in the diagnosis of strain, sprain, especially without any trauma, etc. You should suspect some kind of causes. And in other words, order imaging early. Don't delay it by treating patients for several weeks and then considering imaging. Order imaging early, and in this case it can be crucial because we can in fact demonstrate some of this femoral stability impingement. And then if X-ray is unremarkable in some of those complaints, then order MRI, because it may show some of these labral changes or potential other pathology. Now, when you deal with FAI, so typically we have cam type deformity, which is really just a dysplastic kind of osseous bump that typically develops some kind of morphological changes. We don't know exactly why, but probably some during development, and it seems to be a little bit commoner in men. So typically that osseous bump, which typically located at the head-neck junction, and usually that's what just osseous bump, that's what we would call it. Now, the other type would be a pincer type, when just increased over coverage. Now, in both of these cases, in all of these cases, in fact, there'll be some, especially on movement, with flexion and, if you like, internal rotation, there'll be some potential destruction of the femoral as well as acetabular cartilage, leading to accelerated osteoarthritis. In fact, pincer type seems to be a little bit commoner in women, commoner in men, and mixed type overall is the most common. What kind of age is affected by FAI? Again, men tends to suffer from it a little bit more than women, but still, ages typically we consider anything from sort of 20 to 50, and that kind of age that may present with hip pain and progressive osteoarthritis later on. So let's look at some of this imaging. So typically you can see that cam type deformity with that osseous bump and some of these changes, even joint cartilage is not significantly lost, but anyone with hip pain should be further investigated by MRI, because in this case MRI is crucial for you to determine potential labral tears, etc. But that's basically FAI. Of course, there are more accurate measurements can be performed, and I'll show you that in a minute, but typically by demonstrating that osseous dysplastic bump, that's very effective, especially with 15-degree internal rotation. If you find that feature, sometimes that cam type and also pistol grip, which is a little bit more flat, but it's also, if you like, increased fullness in that area, pistol grip deformity, and that should kind of suspect a femoral stability impingement syndrome. In this case, you can see that osseous bump or cam type deformity, FAI plus relatively significant osteoarthritis affecting this joint with non-uniform joint space loss. You can see subchondral sclerosis, osteophyte, buttressing, intra-articular thickening of that calca of the femur. So in this case, patients already develop DJD. Again, MRI is crucial, and especially MR arthrography that can actually help you to demonstrate some of this labral tears, etc., etc. So in this case, you can see some of these changes, bilateral cam type deformity seen affecting both hips with development of osteoarthritis, narrowing the joint space. In this case, you can see a pincer type deformity that typically kind of affects women a little bit more commonly, and indeed this patient is a female. And there are other features that can demonstrate that pincer type deformity again, so the prominence of the ischial spine, in fact that sort of crossover sign when sort of anterior and posterior acetabular walls tend to cross over in this area, So multiple features. Other kind of interesting or rather important evaluation, something called center edge angle, when you can literally just draw sort of lines through the femur, find the center, and then basically construct it to the lateral aspect of the acetabulum. That should not give you an angle. Typically the normal angle, anything between 18 degrees or rather 19 degrees to about 35, 30, 38 perhaps. Any kind of over coverage or shallowness of that acetabulum is going to be abnormal. So shallowness typically normal, found maybe in congenital hip dislocation or other kind of possibilities, but that increase that pincer type, increase over coverage, exactly again may be more suspicious of femoral acetabulum impingement syndrome. Another feature is something called alpha angle that is also used, and that's crossover sign that is demonstrated in there. Another important feature for FAI, you can see that sort of ossicle that sometimes considered to be a normal variant, but again along these features it may be considered as also acetabulum, one of the accompanying features of FAI. Another feature may be some sort of pit formation, or we call pit synovial herniation pit, or some sort of tiny radiolucent defect, usually from the thickening of the or kind of expansion of the synovial tissue, that may also be found in the FAI cases. Again, MRI is the key. Typically MR arthrography along with other MRI sort of pulse sequence T1, T2 and fluid sensitive studies. In this case, you can see basically intra-articular contrast gadolinium is actually communicating through the labrum, and that indicates complete labral tear and displacement in this case. You can see those significant features of FAI. Plus, you can see that osseous bump deformity right there. That's the CAM with labral tear, so that will progress to severe osteoarthritis and need to be surgically treated. So you need to refer this patient to your orthopedic surgeon, and it has to be literally just shaved off and kind of remove that potential damage to the cartilage. So for more information, please refer to some interesting article on Radiopedia for that. Let's talk about ischemic bone necrosis. It's multiple causes. In fact, some literature kind of shows this sort of long mnemonic, something called plastic rags, to appreciate different causes. But some causes we need to consider. Ischemic bone necrosis is literally just lack of normal, and particularly that would be different. Ischemic bone necrosis is different to intramedullary infarcts, and I'll tell you a little bit more about that. But typically ischemic bone necrosis refers to the necrosis of the subarticular bone, which will then collapse and lead to progressive degenerative joint disease. Now, typically multiple causes, but you should always suspect in the patients who are administering corticosteroids. So steroid administration, very important predisposing factors. Also patient with diabetes, alcoholics perhaps, and a few other cases. But with steroids, typically, as you may know, so typically fat metabolism with steroids is significantly affected. So what you're going to find that typically your bone marrow fat somewhere in the epiphysis will kind of enlarge and sort of thicken, and their size they literally swell up. And that will kind of squeeze some of those vessels that potentially already tenuous blood supply, but it can start sort of squeezing some of those vessels that feed your subchondral bone, and that can induce osteonecrosis potentially. So what's the imaging modality? Well, you can certainly investigate it with X-ray, but unfortunately X-ray will not show you early changes related to ischemic bone necrosis. For that reason, MR imaging will indicate the earliest process. So a few words about that intramedullary bone infarct. Typically, pathologically, it's the same process of basically devitalized dead bone. However, it does not affect the intra-articular area. Now, same causes can be considered, but it doesn't affect the articular region, and it's typically within the medulla. So naturally, for the joint, it may represent, not many complications. In fact, the only potential complication associated with that is eventually, in very few cases, it's just been reported, but it probably doesn't have very significant significance, but it just reported an association of malignant transformation of the intramedullary bone infarct into malignant fibrous histiocytoma. But again, it's probably chances of that are not particularly high. But again, same causes. If you find radiographically, you should consider the same causes as intramedullary bone infarct as basically ischemic osteonecrosis of the subarticular bone. X-ray findings. Here I mentioned to you, X-ray findings are usually quite late. The earliest findings you see on X-ray clinically likely to be late, which means that even if you provide certain treatment such as core decompression to try to revascularize that bone, they will be quite ineffective. So again, the earliest diagnosis, if you suspect it, it should be MRI. That's the earliest diagnosis. Regardless, there's known as something FICAT classification. So what you see with AVN, it's typically initially you may see some of that patchy kind of bone necrosis. Even without significant collapse, you may not see any significant collapse. However, that's kind of basically one of these earlier potential signs. But what you see typically on stage 3 is formation of that crescent sign. And what it indicates, if you refer back to that pathological specimen, it really just all that patchy sort of triangular shape, dead devitalized bone, and then fragmentation of that bone will lead to some sort of articular collapse, and basically some fluid and then joint gas will start interposing there, forming that sort of different density, more radiolucent type density. That's why it's called a crescent sign. And that's usually, again, in stage 3, likely it's irreversible, so it's going to progress to more severe collapse, fragmentation, and destruction of that joint, leading to severe osteoarthritis. So again, the earliest modality, you need MRI. MRI, again, in this case, is the late MRI of that, but the earliest findings you may see just increased bone edema, and that may sort of require some very, very prompt treatment. Again, many of those treatment techniques are quite difficult to really kind of perform, because they usually might be quite late during the disease progression. But regardless, on MRI, there's a classic feature of avascular necrosis, something called a double line sign, where the devitalized, basically you can see an area of dark signal right there. So in other words, no signal from the dead piece of bone, basically in your femoral head, surrounded by a reactive edema in that area. So basically kind of like that inflammatory ischemic type changes, edema in the bone, and surrounded by the zone of kind of extra bone formation around it. So the dark signal around it. So typically that black line followed by basically white line, and then that's what is called double line with some sort of devitalized fragment of that bone. And this is a classic double line sign for AVN. This is coronal, by the way, coronal MRI slice. You can see that bilateral osteonecrosis. And if you suspect that typically this will be systemic causes. Again, corticosteroid, sickle cell, diabetes, alcohol, and a bunch of other sort of Now, if MRI is contraindicated, you should certainly consider bone scan for those patients. In bone scan, typically, you can see an area of where that represents an MRI, that sort of dead, devitalized piece of bone in the femur that's usually photopenic. In other words, there is no uptake, there is no vasculature in there, surrounded by reactive new bone deposition. That's usually area of increased uptake of radiopharmaceutical, and that usually indicates possibility of osteonecrosis. Again, if MRI is contraindicated, CT scanning is the modality of choice that you need. And obviously here you see the progression of that disease with some sort of patchy bone destruction. You can see crescent sign, then gradually some of the cystic changes develop, large cystic, and then gradual sort of collapse of that large subarticular bone extending further, and then it will lead to severe kind of destruction with severe progression of DGD and inevitable progression to severe disability. Earlier, if you caught that earlier, so something technique known as core decompression, we need to literally drill that bone to bleed it as much as you can, and then insert some usually some of that graft from the fibula, and then basically hoping that it will grow in and sort of revascularize that bone. But again, it has mixed kind of results in terms of treatment. Again, some of those cases will end up with complete joint replacement or total hip arthroplasty, as you can see in this case. Again, inflammatory arthritis also commonly can affect the hip. Again, rheumatoid arthritis can affect any joint, synovial joint in the body. In this case, you can see how to differentiate perhaps inflammatory versus degenerative. As you can see, severe axial migration, also known as protrusio acetabuli, and it's bilateral, and you can see also erosive changes plus osteopenia as well, and that uniform joint space loss, that's what signifies that axial kind of axial collapse of this femoral head. So again, that usually speaks for inflammatory arthritis. In this case, you can also see some of this erosion of symphysis pubis and kind of marked osteopenia. So a relatively advanced case of rheumatoid arthritis in this patient. So again, it's relatively commonly RA can affect the hip as well as the knee, but obviously small joints of the hands and wrist, that's you suspect that, as well as cervical spine. Now, the other condition that can affect bilaterally hips, it's typically affecting root joint, is that ankylosing spondylitis or perhaps enteropathic arthropathy that we already discussed. So any kind of spondyloarthropathy can do it. But again, inflammatory pattern is obviously that axial migration. But with AS, that helps to differentiate between AS and rheumatoid. Obviously, it's that enthesopathy of that whiskering, that proliferation of bone with increased that sclerosis. And here you can see changes in the sacroiliac region with ankylosis, and also some of the signs such as trolley track, basically fusion and ossification of the interspinous, as well as facet ligament or capsular ligament. But also you can see that bamboo spine or bridging syndesmophyte. So this is your pelvis affected by ankylosing spondylitis quite advanced. And obviously lab tests, we should remember with RA, typically your reactive, C-reactive protein inflammatory marker is rheumatoid factor, and this is more specific, as I mentioned to you, anticyclic citrulline peptide antibodies is a very specific test for rheumatoid arthritis that's used by rheumatologists. With spondyloarthropathy, remember HLA-B27 and some of those inflammatory markers are quite significant, but most of this case is likely to have rheumatoid factor negative, so it's not the helpful rheumatoid factor in those cases, but HLA-B27 is. So other arthritis you should consider is septic arthritis. Again, you should always suspect it in children, especially, in fact, limping child you should never take septic arthritis off the list. And in this case, you can see radiographically, you can certainly start with X-ray, but unfortunately, when X-ray demonstrates changes of septic arthritis, such as destruction of the joint, loss of that white cortical line, perhaps that permeative type destructive lesion, if that's usually quite delayed, that can actually completely destroy your joint literally within the days, leading to severe ankylosis. So the earliest modality for diagnosis will be MRI. And in fact, in this case, you can see significant effusion around the joint. You can see some of that patchy destruction and increased signal intensity in the femur as well. So diagnosis of septic arthritis. Now, in a child, when you perform radiographs, you should definitely look for joint space widening, and that abnormal widening is something called Waldenstrom sign, because along this collar's teardrop, if you see that widening on the medial aspect, and that widening increases more than 2 millimeters compared to the other side, it's very suspicious of some kind of edema in the joint. Now, it may not be specific for infection. Other causes can do that, but again, infection, you should never exclude that, and that basically because it pushes that femur up, laterally away from the joint, because there's just extra fluid collection in there. So please study some of those important causes. Again, in children, you should suspect it, in diabetics, in patients with pre-existing rheumatoid arthritis perhaps, and a few others. Certainly IV drug users also predisposed to septic arthritis. Again, you start with X-ray, and if it's unremarkable, you should definitely consider MRI as your next immediate step. But joint arthrocentesis, joint aspiration is the key for you to be able to culture it, to look for obviously abnormalities regarding septic arthritis, and start sort of early antibiotic administration. That's most crucial. So other few conditions, something called slip capital femoral epiphysis. So typically you can see this is a severe case. Again, typically develops in younger children, older children, and sometimes kind of large, maybe overweight boys, a little bit more frequently found in African American boys. And typically this condition represents literally some sort of, perhaps some vascular changes or other trophic changes to the growth plate that results to slippage. So that's considered to be like a Salter-Harris type 1 fracture. And that slippage will lead to potential disruption of blood flow to the femur and potential avascular necrosis. So the diagnosis to approach it is something known as Klein's line. Now, of course, you can see radiographically, as you can see here, the growth plate is relatively thin, but in his case, you can see growth plate is sort of thickened and perhaps engorged. You can even see it radiographically. And that can be sort of very suspicious feature, what we sometimes call a pre-slip. And that, obviously, you should investigate it with MRI. And then early referral to a pediatric orthopedic surgeon. In this case, you can see that Klein's line that typically constructed along the lateral aspect of the femoral neck and the head, it should intersect it like you see in this case, or perhaps in this case, right there. So if it failed to intersect, even just abutting it, that's considered to be abnormal, and you should suspect potential slippage of the growth plate or slip capital femoral epiphysis. Again, MR is your modality of choice. Following the X-ray, you start with X-ray, and then MR is most important modality immediately after that, and referral to pediatric orthopedic surgeon in cases of certain abnormalities. In this case, you can also see that abnormality very well demonstrated on this radiographic view. In this case, you can see it's very difficult to determine which side is affected. But again, let's look at the Klein's line. So this Klein's line is normal. This Klein's line is abnormal. So left hip has skiffy that you should consider strongly and order MRI and refer them pediatric orthopedic surgeon. In this case, even MRI, we already see it on X-ray, so certainly pediatric orthopedic surgeon will play a significant role perhaps to fixing that area and pinning it and preventing potential further slippage and disruption of blood supply and AVN. In this case, another condition that you should also consider is something known as Perthes disease, also known as Legg-Calvé-Perthes disease or LCP. This one it's a kind of vascular type pathology, potentially known as osteochondritis, and that kind of affects your femoral head. So typically, the possibility of maybe growth related or trauma or any other kind of idiopathic kind of process that usually disrupts that sort of normal vascularization in the femoral nucleus or femoral head, and it will become sort of a vascular fragmented, potentially growth will be disturbed, which may lead to potential progression of severe osteoarthritis in the future. Now, if the child diagnosed relatively young, at a younger age, it has much better prognosis. The older the age of diagnosis, in other words, closer to bone being mature, actually those are more severe cases. But again, X-ray earlier might just indicate that Walder's trauma widening of the joint due to a fusion. Again, MRI would be most significant as an early stage for the diagnosis. And it used to be a different type of modality, such as fluoroscopic arthrography, but again, with introduction of MRI, that almost became obsolete, less likely to be performed unless MRI is contraindicated. In this case, you can see some significant fusion in the joint. You can see some sort of smallness and fragmentation of that femoral head consistent with Perthes disease. Again, Perthes disease should be always considered in the limping child, along with infection, transient synovitis, skiffy, and perhaps a few other things such as bone tumors, etc., etc. And should be thoroughly investigated, because you should not be one of those people who kind of consider some possibility of growing pain that usually doesn't exist. In my opinion, children should be investigated for any kind of consistent bone joint pain for relatively significant pathology in that area. So again, a referral to pediatric orthopedic surgeon is crucial. Let's look a little bit about some of these neoplasms and other conditions affecting hip and pelvis. So when you think adults, again, any adult with sort of hip pain, especially in cases of existing sort of malignancy, etc., you should always consider metastatic bone disease. So again, multiple myeloma, it will be second most common. So, and then possibility of lymphoma. So if you see some of the lytic destructive lesion or blastic lesion and things like that, so you should always suspect metastasis affecting this area. Again, your modality of choice will be bone scan following metastasis. Now, multiple myeloma should be investigated further by imaging with MR imaging. That would be most helpful, and perhaps prompt referral to orthopedic surgeon or oncologist should also be recommended. But in this case, you can see metastatic bone disease, lytic changes in patients with breast cancer. Again, we look at some of this case myeloma on the next slide, but other condition it potentially may represent with some sort of hip and pelvis pain could be Paget's disease in adults. And again, not always, because sometimes it's actually just silent and just discovered radiographically, or perhaps may present as arthritis because it may lead to secondary osteoarthritis. But typically, discovery of Paget's, depending on the stage of Paget's, but usually the bone appears kind of thickened, more sclerotic, more kind of wavy or wovenness of trabecular, and you can see some sort of potential morphological changes around that area. So very characteristic of Paget's disease. Other condition that may affect children and adults as well, fibroid dysplasia, a little bit commoner in children at presentation, but typically gradual kind of widening and says overgrowth of fibroblasts in the bone tissue, and that usually sort of distorts normal architecture and can also affect that area. So you should take it in consider and differential in children as well. Now, in children, other neoplasms such as osteoid osteoma might be potentially possible. Obviously, osteosarcoma, you should also consider that. However, other very aggressive neoplasm affecting in children of that area will be Ewing sarcoma. In this case, you can see arrow point to some kind of radiolucent, sort of aggressive, sort of lytic type destructive lesion with permeative type destruction. And in this case, MR was performed. That's the imaging modality of choice that you should follow immediately after discovery of radiographic changes tissues. Again, infection, it could be a possibility, but again, in fact, Ewing sarcoma can present very similar to infection clinically and radiographically, but in this case, you can see it's aggressive. It invades the soft tissues, and later on biopsy showed Ewing sarcoma. Now, basically, the rule, if the child is very, very young, sort of younger than sort of 1 or 2 years old, and consider neuroblastoma as a possibility of some of these aggressive neoplasms in this area. But in older child, benign neoplasms consider osteoid osteoma, chondroblastoma, typically affecting the femoral head, most likely. Very rarely osteoblastoma, but typically in aggressive neoplasms consider osteosarcoma and Ewing sarcoma. Now, in adults, of course, multiple myeloma, it's the key to suspect, especially in some of those cases with persistent sort of back and pelvis and hip pain. And in this case, you can see AP pelvis demonstrate multiple lytic foci. They're sort of very well circumscribed, round. You can see some sort of endosteal changes as well, endosteal bone destruction, and that's the diagnosis of multiple myeloma, seen radiographically relatively well. Again, MR imaging is crucial, and you can do myeloma scan, as we already described in the spinal lecture. Other neoplasms, which less frequent but is considered to be still commonly affecting pelvis and hips, is going to be chondrosarcoma, and it's typically maybe low-grade neoplasms or maybe high-grade, like in this case. And typically it starts from the bone, and it can invade soft tissues, and it presents with some sort of calcification sometimes, or even sometimes sort of bony fragments in it, but usually calcification. It can invade soft tissues, some of these O-type or ring-type calcifications that CT scanning, axial CT scanning, demonstrates sort of tumor originated from the pelvis and it sort of invades regional soft tissues. So again, diagnosis of chondrosarcoma may also be considered as a possibility, but it's much less frequently than Mets myeloma lymphoma and other kind of more there will be more common neoplasms, and chondrosarcoma, keep it on the list, but again, most likely consider those three as your Mets myeloma lymphoma as the most frequent neoplasms affecting red bone marrow distribution. Thank you very much.